and then research. I know research is a scary word, right? But what I would say is research is something that as nurses, we would enter in very intentionally. It would be when we see a challenge, maybe we go to PubMed or we see what evidence is out there to address that challenge. Maybe it's something with, we're having high surgical site infection rates, and we don't find anything that makes sense for our patient population and our setting. That is when you think, okay, well, if there isn't evidence out there, maybe we need to create that new evidence. And that at its, heart is what research is. It's a systematic process to create new evidence.
Welcome to Nursing Beyond the Bedside. I'm Audrey, your host, and a nurse who pivoted my path several years ago. After 8 years as a critical care nurse, I was ready for change. I craved higher pay and more flexibility, but was struggling to find a clear path forward. Fast forward through positions in recruiting, customer success, and marketing, and many lessons learned along the way. Today, I run Pivot Path, a company dedicated to empowering nurses to redefine their careers. This podcast is designed to help you navigate the journey from clinical bedside nursing to a fulfilling career that aligns with your passions and goals. Here, you'll discover inspiring stories from nurses who've gone beyond the bedside, successfully transitioning to non-clinical roles, or redefining their nursing career. Join us as we hear their stories and share actionable strategies to help you make your own leap. Whether you're a new listener curious about what lies beyond the bedside, or a returning audience member in need of some fresh motivation, this podcast is your go-to resource for exploring new opportunities that can transform your career. Let's get started. Today on Nursing Beyond the Bedside, we're joined by Dr. Danielle Sarik, a pediatric nurse scientist and health services researcher who's making waves in healthcare through policy, innovation, and research. She's the mind behind the American Academy of Nursing Edge Runner designated Baby Steps model, which is transforming how we approach care transitions for NICU patients and their families. With multiple degrees from the University of Pennsylvania School of Nursing and Cornell University, Dr. Sarik is actively shaping the future of pediatric healthcare through her work on the National Pediatric Nurse Scientist Collaborative and the Institute for Pediatric Nursing. She's here to share her journey and show us how nurses can leverage their expertise to create systemic change in healthcare. Danielle, welcome to the show.
Thank you so much for having me.
Yeah, it's such a pleasure to have you on to chat with us today. And I know that we have a lot of really important topics to cover, but why don't we go ahead and start with just kind of an overview of your career evolution from health policy to nursing to where you are now?
Sure. So I like to say I'm a non-traditional nurse. So nursing is a second career for me. My first career was in health policy. And so, when I kind of talk about my nursing career, what I like to talk about is the fact that I have, from the time I was very young, I've always wanted to have some sort of a career caring for children. And sometimes I feel like that sounds really cliche, right? Like I want to take care of kids, but recently my parents were moving and cleaning out their house that I had grown up in. And I had journals there where I have written in them about, as a child, like I want to be a pediatrician or I want to be someone who takes care of kids when I grow up. So, from a very young age, I think I had this feeling that, for me, that was going to be something that was important is being in a career, being in a profession where I could provide that care. So when I went to college, I started at Cornell. I studied biology and society, and I ended up minoring in global health. And through that process, I actually, I'd never been outside of the country. And so during that process, I did a program where I went to Shanghai and I spent some time learning about their healthcare system there, learning some of the language, learning about traditional Chinese medicine. And it really kind of opened my eyes to thinking about healthcare and providing care in different ways. So from there, that's when I got more interested in the global health perspective and the policy perspective. I also had the opportunity to spend a month, actually several months. Had about 3 months in Nicaragua caring for moms and babies in a maternal waiting home, which is kind of a model there where women from rural areas, when they're ready to deliver, they come more into the urban area so they can be close to a hospital, but they often have to be there for a while because they're not sure how far along they are. So, I had those experiences. I, worked kind of on the ground in those places. And when I graduated, I wanted to do something that would kind of continue that experience and then also help me to work more at a system level. So I started my career after college working in global health. I went to an organization called PATH, which is a organization headquartered in DC and Seattle. They have offices around the world, and they do a lot of work around technology for health. And I was a policy and advocacy associate. So I kind of had my hands in a lot of different things. I had the opportunity to support different programs ranging from, domestic violence to tuberculosis to child and maternal health. So really kind of wide-ranging programs, but with the underlying goal of improving health. And so, I was in that role, and that was really when I first learned about nursing. And so that was kind of my pivot, right? So I was in this global health role. I really enjoyed it. I really enjoyed the policy piece. I went to the Hill to advocate for different policies. I wrote white papers. I worked on grassroots campaigns, but I got to work with nurses in this role. And I had no nurses in my family. My undergraduate at Cornell didn't have a nursing program. And so that was the first time I really looked at nursing as a career that was maybe not just the clinical career. And I worked with a wonderful nurse there. Her name was Deb. She led the postpartum prevention program, which worked with women in developing countries, resource limited areas to provide a single use oxytocin injector. So for all of our maternal or L&D nurses or, anyone who's had a baby, oxytocin is that hormone that's released after you deliver that helps to stop bleeding and, help you not to have a hemorrhage. And so working with her, I kind of found this role for nurses that I had never known about. So clinically informed, but then also with, additional programmatic training and research training. And that's when I decided to go back to nursing. So not like necessarily the traditional role for sure.
Not at all, but what a cool perspective to bring into a nursing career from the very beginning, because your perspective was global,
Yeah.
and you had seen healthcare applied across cultures and other ways of doing things rather than entering into nursing school and getting this like singular kind of like institutional education on like what it is that nurses do and like how we do things here. So I think that bringing that perspective into it from the very beginning is so special because also, like you mentioned, you had already seen that nurses could be more than just hands-on with patients in their career. They could do like so much beyond that. So I think that's such a fascinating foundation. And it really makes sense for the path that your career has taken. Where was it along the way that that interest kind of sparked for you to become a nurse scientist?
I think that for me, kind of, what you were saying, being in these different healthcare systems and kind of seeing the things that were very different culturally, but some of those challenges that were universal made me think about, okay, what is my role in this system and how can I approach this so that I'm not just working on the individual level? Maybe I have this ability to impact people's health and healthcare systems at this systematic level. So for me, I think, when I went back to school, I went and did a second degree program. My goal at that point had been to become a pediatric nurse practitioner and to go back and get an MPH because remember coming from the global health background and the policy backgrounds. But when I was enrolled in that BSN program, I worked as a research assistant or an RA in the Center for Health Outcomes and Policy Research. And the director of that center was Dr. Linda Aiken, which again, I think a lot of people who are in nursing are familiar with that name. She's a giant in health services research, really has done a lot of the groundbreaking research about nurse staffing ratios and patient outcomes and education for nurses and patient outcomes. And so, I worked in that center as an RA my whole time in the BSN program and then while I was enrolled in the MSN program. And I think that experience of being around nurse researchers who were looking at that system level combined with that global health and policy background where I already kind of had this strong belief that we can make big changes for multiple people if we work at that system level. Those things combined, I think, made me really interested in a career that I'd be able to have a different sort of impact. So, I got my PNP, I worked in the primary care setting. And then when I went back for my PhD, I knew from the beginning I wasn't interested necessarily in that traditional kind of academic path, which there's nothing wrong with that. We need nurse researchers, we need people in academia to be teaching the next generation of nurses. I just, for myself, felt like I was more called to be closer to the bedside or working at more of that policy or that system level. So I was able to have conversations with folks, and that's when I learned about that nurse scientist role, the clinically embedded nurse scientist role. And so during my PhD, I was able to talk to nurse scientists, learn more about what it is that they do. And then after I graduated, I found a position as the director of nursing research, and that was the start of my career as a nurse scientist.
And I know that many of our listeners might not be familiar with the term nurse scientist. I feel like nurse scientist is not a path that I was aware of. I mean, for a long time in my nursing career, and especially not when I was going through nursing school. So can you kind of break down exactly what a nurse scientist is and what that means?
Sure. And this is a question when I talk to nurses who are in school or nurses who are looking for maybe a less traditional career, it's a question I get a lot. What is a nurse scientist? So when I think about the definition of nurse scientist, the base is that you have a clinical degree as an RN or an APRN, because that clinical piece I think is so important to what the nurse scientist does. But then in addition to that, in general, the nurse scientist also has training or expertise in research. So traditionally, what that means is that the nurse would then get a PhD, get training about how to conduct research, how to evaluate research. I do work with some nurse scientists as well who have doctorates of nursing practice, so DNPs. So they're more expert in that translation of, evidence to practice piece. But generally, the kind of formula is a nursing degree plus an advanced doctorate.
And you mentioned that with your role being a clinically embedded nurse scientist, what does that distinction look like?
So what that means is that my role is actually within the healthcare system. So I have a position where I report up to the CNO of the healthcare system. And the work that I do is very focused on improving our systems of care from the time that a patient comes into the hospital to when they go home. So really that whole continuum of inpatient care. With that, what I love about that role is that I get to be really close to where our patients and families are. And for most of our patients and families, being in the hospital is not a great experience. But what I think is really valuable about being a clinically embedded nurse scientist is that you get to make that process maybe a little bit better. And you get to look at where our challenges or our gaps might be in care and partner with clinicians so we can address those challenges in real time. So there are a bunch of different functions of a clinically embedded nurse scientist, different roles you could have, different tasks you can do. But one thing that I think is interesting about the role is that it can be different from hospital to hospital. It can be a very unique role based on you as an individual, the skills you bring, and the needs of that health system or hospital that you work in.
Yeah. And you mentioned kind of identifying these like gaps in care and helping to come up with solutions. You were behind the baby steps model. Can you tell us a little bit about like what that is and what inspired the creation of that?
Sure. So as I mentioned, I did work as a pediatric nurse practitioner. I was in the primary care setting for about 7 years. And through that experience, I got to do a lot of work that was really exciting. I got to, help support patients and families through their care continuum. But unfortunately, what that means is I also saw where we had gaps in care and where we, as a healthcare system, really sometimes let down patients and families. So one of the visits I would love to do when I was a PNP would be the newborn visits. And so for any of you who have had a baby or who have worked in that setting, you know that within the first couple of days after a baby goes home, they generally go to the primary care office, they get weighed, the parents get anticipatory guidance, we make sure all the reflexes look good. And if there are any concerns or any follow-ups that need to be done from when they were in the hospital, usually that PCP is kind of like a first point of care. So when I saw those visits, often I would see, excited parents, of course, but then sometimes we saw where we had opportunities for better follow-up with the families, where we had challenges with the parents or the families understanding the instructions that they had gotten in the hospital. For our babies who were coming out of the NICU, what that meant is sometimes we had families with real challenges with accessing like those specialty care follow-ups or getting their equipment they needed for their baby. And that often led to a lot of frustration. And, apart from frustration, we also saw sometimes negative outcomes from that. So, that kind of time in the primary care setting, definitely that clinical experience and that experience of seeing those gaps that has guided my research interests. And then, back about 5 years ago now, one of my colleagues had a baby of her own, and her baby was hospitalized in the NICU. And during that process, there were some challenges, and she reached out to me as a, pediatric nurse practitioner, questions about transition to home, some concerns. And I was able to kind of chat with her and guide her through that. And together, my colleague, her name's Dr. Yui Matsuda, and I, we realized that, that's something that the majority of people do not have access to, right? They may have a primary care office, but they don't necessarily have the ability to just pick up the phone and talk to someone who will be there to, answer questions or just provide kind of support through the process. And so, that clinical experience of being a PNP combined with that life experience of having worked with someone who had gone through that discharge process together, that was really kind of the impetus for developing the baby steps model.
Yeah, that's awesome. I mean, having pregnancy and childbirth is a normal and natural physiologic process. However, it comes with overwhelming information and responsibility. That's if you're having a healthy baby. Like if you have a baby who does spend time in the NICU and has special needs after discharge, like that just totally increases the amount of like education that needs to be consumed by the parents. And just, I mean, it's a massive thing to take on. And I think that, developing these processes that can like better support new parents in that process is awesome. And like, can you tell us any more like specifically like kind of how that model addresses like kind of health equity and like supporting those patients and families?
Sure. So first of all, I think it's important just to say like this is not a unique experience, right? In the United States, about 1 in every 10 babies spends time in the NICU after birth. So it's highly likely you either know someone who was a NICU baby or you love someone who has a baby who was in the NICU. But it's really, I think in some ways, it's really kind of interesting how universal it is. And luckily, we've had great improvements in our care for premature babies. And so we've had really good improvements in our outcomes. So, it's even though it might be really scary, often, those babies who have to be hospitalized, they tend to do very, very well. However, I think something that's important to note is that experience of being hospitalized is not necessary, or experiencing prematurity is not equal across everyone. So we know that for prematurity and NICU hospitalization, historically marginalized groups bear the burden, right? And that way it's kind of a reflection of some societal norms that, we have babies who tend to be hospitalized and born prematurely more frequently. So when we were thinking about this model, of course, we want it to apply to everyone. We think everyone deserves to have the best possible transition from the hospital to the home setting. But what we also realized was that there was this big gap for particular babies, right? What we also realized once we started looking and, kind of seeing what the research said was that social determinants of health, so like those things like whether or not a family has access to a car, whether or not they have, a secure financial situation, whether or not they have the ability to speak the language of, the clinicians that are providing care for them. When we have adverse social determinants of health, we see that there are additional challenges in that transition from hospital to home, which makes sense, right? Like it's already such a confusing system to navigate when speaking for myself, native English speaker, a pediatric nurse practitioner, well-versed in the policy side of things, it is still challenging for me to figure out my health insurance some days, let alone
Yep.
navigate insurance and medical home equipment and visiting nurses and specialty care that your premature baby may need when you yourself are physically recovering. And on top of that, you have a newborn you now have to provide care for. So at baseline, that transition can be challenging for anyone, but we know one, that disproportionate amounts of historically marginalized babies are in the NICU. And we know that after discharge, those with adverse social determinants of health are going to have additional challenges during that transition period. So we developed this model to really apply to anyone, but to address some of those things that we saw as being those key determinants that caused some poor outcomes. So one of the first things we looked at was language. In our setting, about 70% of our families, Spanish is the preferred language in the home setting. So right away, we knew that we needed our follow-up care to be provided in the language of our patients and families. And so what that means is that our NICU nurses that are providing these follow-up calls, they provide them in Spanish if the patient's Spanish, if Spanish speaking. If not, if there's a different language, we use iPads that have real-time interpreters that join so that it can be in the family's preferred language, which is so key and sounds fairly simple. But when you actually have to figure out the processes and, incorporate it, it can be challenging. And so
Hmm.
that was kind of a priority for us. We also wanted to make sure that there were no financial barriers to using the program. So we were able to secure grant funding as well as institutional funding to make sure that if a patient, or not a patient because the patients are newborns, but if a family didn't have access to a smart device to be able to do the telehealth calls at follow up, that we were able to provide them with a loaner iPad to do that. Also, the program is available free of cost. So it's not at this time billed for, charged for, so we eliminate that as a barrier. And then it's also really important that we recognize the cultural implications of care, right? So, especially in nursing, we are taught you provide holistic care for the whole person.
Hmm.
And so that is something that we try to incorporate into our calls as well. So the model itself is pretty simple and pretty straightforward. If a baby is admitted to the NICU, we have a NICU nurse who's one of our baby steps nurse visit that family at the bedside before the baby goes home. We explain the baby steps program, we enroll them in the program, we teach them how to use the telehealth technology, which we use to connect with them. And if needed, we do a call, like a mock call with them. When the baby and the family go home from the NICU, we set up a call with them within 48 to 72 hours after discharge. The reason for this is we know that in that first day or two, they're probably going to their primary care office. We hope they're going to their primary care office. But because we know that sometimes there can still be confusion and concerns, we want to have our call after that point so that we can help to guide the families through that. So we set up a telehealth visit with them, and then a NICU nurse who either speaks their language or has a real-time interpreter connects with them via telehealth and goes through basic anticipatory guidance. So remember, these are NICU babies, so they may have technology, they may have special feeding requirements, but at baseline, they're still babies, right? They still have to do all the things babies do. So we go over those things that are important for all infants: safe sleep, right? On the back, making sure there's nothing in the crib that could be a danger. If the babies are on oxygen, talking about what that means as far as not having candles in the room or flames around the baby. We talk about feeding, mixing formulas, human milk, breastfeeding, all of those baby things that are really important. Because it's a telehealth intervention, if there's a clinical thing, maybe mom's concerned about the belly button or wants the nurse to look at, a G-tube site, something like that, they can do that in real time. So they don't have to take their fragile, vulnerable newborn baby back to the office. They can do it from the comfort and safety of their home. And then we have guidelines about what's within nursing's scope, right? Remember, these are NICU nurses, so they're well versed in babies. But
Hmm.
if it's something that's outside of the scope of nursing, we then would escalate it to our physician colleagues or our APRN colleagues to make sure that we can appropriately guide that family, whether it's something they can look at, deal with at home, watch and wait. If they need to go back to the PCP, or if we recommend they immediately go back to the hospital. And so that's the one call we schedule with them. After that point, for the 2 weeks of the intervention, it's up to the family about how much or how little they want to use the service. So we have families who require more support and they want to talk to us daily. And then our nurse would be available to them on a daily basis. Could just be a check-in. They might just want to talk about how they're mixing their formula. It could be to connect them with resources in the community. We find that that's a big concern for our families is, that kind of social piece of either, connecting them with WIC or connecting them with community resources, connecting them with mom groups, those sort of things. And then they can access the service as many times as they'd like for that first 2 weeks. We stop at 2 weeks because at that point, we really want the family to be transitioned to their providers in the community. It's past that initial kind of acute period, and they should be developing those relationships. So that's, it's not a big kind of crazy intervention. It's very short. The main kind of crux of it is it's nurse led and it's that culturally informed piece. And what we found is that, it actually makes a huge difference for our families.
Yeah. And, I have to chuckle a little bit when you say that the model itself is actually quite simple, because nothing in healthcare is that simple, especially when it comes to actually implementing that within existing, clinical workflows and being able to dedicate the time and resources to something like that. That's like moving mountains in the world of healthcare. So that's a huge accomplishment that you guys have been able to, develop and implement that. And I know that it's making, huge differences for your patients and their families. Because we touched on kind of like the health equity piece and social determinants of health. If it's okay with you, I kind of want to, we have a piece of our conversation that I still want to hit, but I want to kind of use that as a segue to jump ahead to nursing using their voice in healthcare policy. Why is it so crucial for nurses to be involved in healthcare policy?
So I could talk about this for hours. So I will say very succinctly, I think that one of the reasons it's so important for nurses to be politically informed and engaged in policy is because nursing is inherently political. And what I mean by that is who gets care, the way we deliver care, the systems in which we deliver care, that is all determined by policy. And so it doesn't matter, your political affiliation, but as a nurse, I think it is very important that you are able to understand and connect the work that you do for your patient and the work that you do kind of at that individual level with what's happening at the state or federal level. So that would be my answer. The reason that I think it's really important is that policies really impact the care that we're able to provide and the way that we provide that care.
And what do you think is a misconception among nurses about getting involved in policy work?
This one is easy for me because, throughout my career, I've had different positions within volunteer organizations of like legislative chair or legislative lead. And so I've had the opportunity to lead lots of different types of nurses to go to Capitol building, state capitol, national at the national level. And one of the things that I always hear from nurses who haven't really done a lot of this work is, why would they want to hear from me? I'm not a policy expert. So I think the biggest misconception is that to engage in policy as a nurse, that you need to be a policy expert. If I could tell every single nurse, you don't need to know what the meeting schedule is for your representatives. You don't need to know when they're in session. You don't need to know about specific bills or specific like pieces of legislation. If you do, that's a plus, that's great. But really the biggest piece of being involved is you being an expert and standing in your nursing expertise. And so what I mean by that is, and I'll give an example from many years ago, when I was in Pennsylvania, we were working on full practice authority. I arranged for a group of nurses to go to the state capitol to meet with lawmakers about what is full practice authority and why do we want it and why do we think it's a positive thing for our patients and families. And in the first couple of meetings I had, every single person we met with, they didn't understand the difference between an RN and an APRN. They didn't understand when we said we were nurse practitioners, what that meant versus being a registered nurse. And so that took no policy expertise, but that was our expertise as nurses. We were able to explain why advanced practice registered nurses, why we would want to have full practice for what we've been trained and educated to do. And so then after we kind of cleared up those misconceptions, we were able to kind of move down the path of, okay, what would this mean for the patients in the clinic that I work in, which is a clinic that serves uninsured and underinsured children. Well, what this would mean is that we wouldn't have to have this additional contract to pay for, prescription authority so we could provide medication for strep throat. And that's really important to us because we often have underdiagnosis and undertreatment. And so then we have children who have rheumatic fever. And then we have the consequences of that. So in that way, I think what I would want to tell nurses is what you bring, the value you bring is not knowing the political system. It is a
Mhm.
beast. People who work in it will tell you that it is very confusing. The value you bring is your own expertise as a nurse and the stories you can share from your patients and families. Again, I think one of the things we're taught as nurses is to advocate for our patients and families. So many
Mhm.
of the us to that for us, what that might mean is, okay, I know that my patient has pain that's not being touched by our current regimen. Okay, we need to assess, treat, reassess. If it's not working, I advocate to change the regimen. What that means in the system level is if we see policies or structures that aren't working for our patients, we can be their voice to let our representatives know. So again, I'll share information about when I did a Hill visit talking about funding for vaccines. And, I know at this point in time, this can be slightly controversial, but for someone who's been trained in the traditional medical model, my understanding was that, or my understanding is that, vaccines are a really important tool that every child should have access to, regardless of their ability to pay for it with private insurance or, whatever. And so we had these meetings, and what was important to the representatives that we were meeting with is they said, well, don't all children already have access to vaccines? Like, isn't it really easy? And then we were able to share from our own individual practices. Well, actually, these are the challenges that we hear from our patients. They have to go to a particular place. They don't have transportation to get there. If they try to go to a pharmacy to get the vaccines, the pharmacist won't give it to children under a certain age, so they're not eligible for it. And we were able to share that expertise, not the policy expertise, not how what are the policy levers, but really like on the ground, what are the challenges our patients are facing in getting the care that they need. One of the other things that I'll share, I think was interesting to me in doing visits, and for those people who have never gone on a Hill visit, even, gone to Washington, D.C., the people you meet with are often very, very young. So we might have this idea of like policymakers, like our elected officials, they might be older, but the people you actually meet with, the legislative aides, they tend to be recent college graduates. And so, that's a great opportunity for you to kind of meet these people, build relationships, and they may know a lot about a lot of different things, but maybe not about the area that you have expertise in. So say you're a nurse with expertise in oncology or a nurse with expertise in, diabetes and transition of care for newly diagnosed children. You can kind of teach them, and they're sponges, right? They want to know because they're interested. They want to do good work, but sometimes they just need you to provide that expertise. So yeah, I would say don't be intimidated by feeling like you have to know how everything works in policy, and don't be intimidated by thinking you're going to be meeting with, your senator when you go. If you get to meet with your senator, it'd be great. But in all of my years of doing this, I've never had that opportunity. So
I think that you said something very powerful in all of that, and that is standing in your nursing expertise. And I think that applies across the board, like policy and beyond. Like nurses have such specialized knowledge. And it's knowledge that, I mean, really, unless you are working within the healthcare system and then even down to like within a specific specialty and patient population, that expertise is not easy knowledge to come by unless like you are in those roles, boots on the ground. So I think that whether it's policy or, a new job that you're applying to or someone you're consulting with, like standing in your expertise and like being proud of knowing what you know and recognizing that your clinical expertise is a piece of a puzzle. So like if it's policy, for example, like you said, like you don't need to know the policy, like the lawmaking policy part. You don't need to be an expert in that. But if you can bring your clinical expertise and pair that with somebody else's expertise and like the policy and lawmaking, that's what you need to actually like make things happen. So I'm glad that you said
absolutely.
that.
Yeah. And
Yeah.
what I would say about the pairing piece, just to follow up on that, is that I would say if you're a novice in this and you're not super comfortable, you haven't done it, the best thing to do is to partner with your organizations, like your nursing organizations that represent you. So, whether it's your state nursing organization or if you have a specialty care organization, almost every nursing organization has some sort of advocacy policy, either committee or a person that helps to manage that. And often, if you go to their websites, they often have resources on their websites. They might, have a function where you could sign up for text or emails if there's something that's really pertinent to nursing. For example, there was legislation recently introduced to have a $2,000 stipend for nurses who precept at the federal level.
Mhm.
So I got a ping to my email about that because that came through like a national organization, like, hey, this is nurse legislation that could positively impact nurses that you should know about. And a lot of those organizations as well, they will have what they call like an annual Hill Day or a policy day where they help to guide a group of nurses to go and meet with their representatives. And the really nice thing about that is they often do the legwork for you. So they'll set up the visits. They ask, what's your zip code or where do you live or work? And then they'll set them up so that you can kind of be, led through the process and maybe do it with someone who has a little bit more expertise. And they're often also give you what you need as far as speaking points. So like, these are kind of the issues we want to address. And then you add to them your own voice, your own experiences, your patient stories. And that's what really brings the meetings alive.
Yeah, I'm so glad that you followed up with that, like kind of resources and actions that nurses who are interested can like go ahead and start engaging with. If there are any nursing educators listening, like I wish that this was more of the nursing curriculum in nursing school. Like I think that it would be so powerful to get nurses involved and like knowledgeable about this earlier on that they do feel a little bit more comfortable. But I think that your tip on engaging with professional organizations on this is perfect. And so we've covered a lot on policy, and I want to go back just for a little bit for talking about nurses and scholarship. And I know that many nurses may not totally realize that they're already doing elements of research in their daily practice. Can you speak to that a little bit?
I would say that every nurse is an innovator because you have to be, right? Like you are at the bedside and something isn't working correctly. What do? You come up with a solution. We don't sit there and wait and say like, oh, I wish this would be better. Or like, oh, no, you like find some tape, you like tape it to the pole to make it work better. So I think in that way, inherently we're innovators. And so
Mhm.
what that leads to for me is we are also the ones who are seeing those problems as they occur. And so I think that one of the ways that nurses often are using or engaging with scholarship and they don't recognize it is if they see an article that comes out about like some new care practice, or maybe they, saw a poster at a conference and they wanted to bring something back. That is scholarship, right? So we have a couple of like major categories that I usually guide nurses into as far as when they want to engage in scholarship. The first is research, the second is evidence-based practice, and then the third is quality improvement or QI. I would say almost all nurses are doing some sort of evidence-based practice. It may be informal, but you are, learning best practices from other individuals, from other organizations, and you're applying it to your practice. I also think a lot of us are doing quality improvement, right? We have a system at the unit level that maybe isn't working right. So maybe it's something about when we take our patients off unit to go for imaging, there's some sort of a delay. We don't have a smooth process there. So we end up wasting transport time. We end up getting frustrated patients and families. And it just generally isn't a good system. So what do? We take a step back, we look at it, we think about like, okay, well, why is there this delay? What can we change? Maybe it's that we have, instead of the nurse going off the unit to take the patient, we have a transport person come. We look, we see if that improves the process. If not, we go back, we tweak some other things. That's what we call an iterative process. That's quality improvement, right? We're looking at our systems, we're changing something in the system, and then we're looking at the outcome to see if it changes. So I think we often do these things without giving them the formal title, which is okay. But at the same time, I think if you're able to partner with someone who has a little bit of that kind of terminology or has that expertise, you can just take the work that you're doing to the next level. You can take it to presenting at a conference. You can take it to putting together a podium presentation. It can be highlighted as something that the system did positive. So those are all really good things. And then research. I know research is a scary word, right? But what I would say is research is something that as nurses we would enter in very intentionally, right? It would be when we see a challenge, we try to maybe we go to PubMed or we see what evidence is out there to address that challenge. Maybe it's something with, we're having high surgical site infection rates and we don't find anything that makes sense for our patient population and our setting. That is when you think, okay, well, if there isn't evidence out there, maybe we need to create that new evidence. And that at its, heart is what research is. It's a systematic process to create new evidence. What I would say is that if you are not someone who has research training, but you see a problem that you think is a research issue, you should try to find that person, that nurse scientist in your setting. Sometimes it would be a professional practice specialist. Maybe it's a academic affiliation that you still have. You keep in touch with one of your professors. You know this is an area of interest for them. And allow them to help guide the research process while you as the clinical expert guide that clinical piece that's so important. Research does tend to be a longer process, right? It has to be systematic. It can take a longer period of time. But the benefit with research is once you generate that new knowledge, not only does it benefit you internally, you can disseminate it, and other hospitals and other nursings and other settings can use it. And so the investment is a higher investment, but sometimes the impact can be much greater as well.
Yeah, I was just going to say that impact goes to a much broader level, which, is incredibly fulfilling. Like we get such fulfillment just from working one-on-one with our patients. So, imagining, being able to, research and implement something that, affects the outcomes and experience of patients everywhere, is just incredible. And I know that, you mentioned that nurses, we're seeing the problems. We understand these clinical workflows. Mm-hmm. You have also taken on some consulting work. And so tell us a little bit about what services and expertise you provide and what motivated you to kind of start that up.
Sure. So, in my role as a nurse scientist, I have had an opportunity to work in different institutions that are standalone pediatric institutions. And so, that might be a place where the organization has the resources and they're able to invest in a person like me to be in that institution to educate nurses, to support research, to, pursue my own research, to help with policies at the system level. But not every health system is at that place, right? So a lot of us are probably in settings where there isn't a nurse scientist or there isn't somebody who's specifically dedicated to doing this work. And so, part of the idea with creating, the ability to consult is that one, I love doing this work. Two, I think all health systems would benefit from having someone to help guide them in this work. And so, that's essentially the goal of the consulting organization is to be able to provide expertise in research and evidence-based practice to healthcare settings that are in need of it. And so, that could be anything from helping to provide support for, the scaffolding for putting together research. It could be helping nurses to write up research findings. It could be putting together a strategic plan for a 5-year goal to really elevate nursing scholarship and to, be able to start publishing. One of the things that I think really drives hospitals and health systems to invest in nursing scholarship is magnet designation. So for those of us who work in hospital settings, we know that the magnet designation is basically a gold standard that is showing that your health system or your hospital is a place that attracts and retains nurses and has processes in place to elevate that role of the nurse. And a big part of magnet redesignation or designation is demonstrating that your nurses are doing EBP and research. And so, that's also a piece of it is that if you're an organization that doesn't have the resources to fully invest in a full-time person, it's helpful to be able to reach out for consulting expertise so you can move towards that magnet designation.
Yeah, definitely. And I love that you call out the magnet designation too as kind of like a motivation for getting you in there and doing that type of work. Because I know that that's something that these hospitals really strive for, it's a great thing, especially in the staffing world today, to be able to say yes, we prioritize this. We're able to retain nurses. We have these systems in place. So that makes total sense.
Absolutely.
So Danielle, what is next on the horizon for you?
Well, right now, with the Baby Steps program, I'm in the beginning of 3 years of funding from the Betty Irene Moore Foundation. So I am a fellow with the Betty Irene Moore Nurse Leaders and Innovators. And so that funding is going to allow us to really take that program to the next level. So working on launching that study that's going to look at a qualitative analysis of the outcomes of babies who receive baby steps. And then from that, we'll be able to really hear from the voice of our families, our caregivers about what's working and maybe what we need to improve, with the hope that this model, we can continue to scale and spread it. So, right now it was developed in a single institution, but the goal is that, as an evidence-based intervention for transition of care for NICU babies, there is really not anything out there, right? And so the goal would be to really create this program, create this model so it's accessible for NICUs, for, hospitals that are caring for infants, caring for newborns, and rolling it out and then looking at the outcomes across different settings. The reason that's important to me is that, again, that whole idea about creating new knowledge, we don't want to just hold on to this great program that we developed in one place. We really want to make it accessible for others. And ultimately, that idea to, have more health equity, to really provide evidence-based, nurse-led transition of care for some of our most vulnerable infants and families. To me, that's really exciting. So, looking at really excited to kind of get that going over the next 3 years. And then after that, planning to do some multi-site work. So, doing clinical trials in multiple different NICU settings. On the policy side, for me, I think my commitment to improving care for all children is something that, I said in a very cliche way, this is something that's been kind of central to who I am for as long as I can remember, is caring for children. And so I'm going to continue to, engage in ways that make sense in order to make sure all children receive the best possible care. To me, I think a big part of that is making sure we're following evidence, making sure that we are supporting programs that have really good demonstrated impacts, and working with my national organizations. So I'm very active in NAPNAP, which is the National Association of Pediatric Nurse Practitioners. I have a leadership role as a legislative position with Institute of Pediatric Nursing. So doing a lot of pediatric workforce work with that group to make sure we have a really strong, robust pediatric workforce to care for patients. And then I'm also on the executive board of the National Pediatric Nurse Scientist Collaborative, which is a wonderful organization. If anyone is interested in the role of nurse scientist, I would definitely check them out. They have a website that has pediatric nurse scientist members from across the nation. And so through that organization, we're able to get a really good kind of pulse on what's happening with our children, our pediatric populations nationally, and then work together to kind of look at different research that we need to do to make sure we're moving care forward. So that will keep me busy for the next few years, probably. And other than that, just, continue to have fun with research. I know that lots of people don't think that's possible, but working really closely with the clinical nurses in my setting, and just, making sure that we're really working in a concerted way to improve clinical care for our kids.
Exciting stuff ahead. It's so awesome to follow along with the work that you're doing. So
thank you.
I'm excited for you, and, looking forward to seeing what you make happen over the next few years. So thanks so much for coming on and chatting with us today. I think it's been an awesome discussion. I think you shared a lot of information on topics that nurses aren't super familiar with. So thank you.
Wide ranging for sure. And I would just say, in closing, that, if any nurse is listening to this and kind of thinking like, where do I fit in, or do I fit in? Because my path is different, or my interest is different, or I don't see anyone who looks like me pursuing whatever the role is. I would just say, like, believe in your own path. You are forging your own path. It doesn't need to look like anyone else's. From today, you can probably tell my path was not super straight and had a lot of twists and turns, and that's okay. You will find your own way. You will make your own impact, and just, don't be afraid to reach for the things that you really want, and don't put yourself in a box.
If you'd like to connect with Dr. Sarik after today's show, you can follow her on LinkedIn or find her on her consulting website that's included in the show notes. Thanks for tuning in. Don't forget to hit subscribe to keep up with our latest episodes. And if you were inspired by today's conversation, I hope you'll share this episode with someone who'd love it just as much as you did. If you're ready to pivot your path, sign up for my free newsletter at mypivotpath.com. Get non-bedside jobs delivered to your inbox every week. And if you have questions or just want to say hi, feel free to email me at audrey@mypivotpath.com. Thanks for listening, and until next time.